So thank you for this session, sir. Pata sir, we are meeting after a gap in HPP diseases. So to restart, last week we did some work on the LGS group on acute pancreatitis, the study group.
Can you make it full screen,
and we did it.
Ilango, full screen.
I'm talking as a moderator from the Learning General Surgery group. So our focus today will be on the fluid resuscitation in acute pancreatitis. We wanted to do some study because we are a large group of 33,500 members. And I'm sure if you're able to put our data together, I believe that we will be able to answer some of the unanswered questions in acute pancreatitis. So the objectives of this presentation, I think you have heard lots of presentation on acute pancreatitis. So I wanted to be very focused, which may be useful to seniors and senior trainees. So in this presentation, I'm outlining the treatment protocol of, just look at the brief treatment protocol of acute pancreatitis. We understand the current knowledge available on fluid resuscitation. I will also break down the individual parts of fluid administration as much as I have understood. And I will also list some unanswered questions and how we can address them in the future. So in the initial 72 hours in the management of acute pancreatitis, probably these are the things which I would consider very, very important. A proper diagnosis, to predict the severity of the disease, initiate early fluid resuscitation. In biliary pancreatitis, decide whether you need urgent ERCP. Initiate early feeding, alcohol counseling, and in biliary pancreatitis, you should also, I missed that point, you should also plan for same admission cholecystectomy. So these are the most of the recommendations talk about these things. So today we are going to talk about the initial management of acute pancreatitis in a slightly deeper sense. So in acute pancreatitis, what exactly happens when the fluid loss happens? So there is a lot of alteration in the pancreatic microcirculation. We've always seen that the pancreatic microcirculation is very fickle, and if the blood becomes thicker, the flow through those small microcapillaries are extremely slowed down. So an alteration in the microcirculatory circulation of the pancreas is because of arteriolar vasoconstriction. There is an increased capillary permeability. There is a capillary perfusion failure. There are changes in blood coagulation and changes in blood viscosity. Pretty much things which we don't see in clinical practice, but they lead to pro-inflammatory cytokines and vasoactive factors being released into the blood circulation. What then follows is an ischemia reperfusion type of injury, what you see in transplantation, which accounts for major acinar cell damage. Now this culminates in an intracellular activation of proteases and leads to tissue destruction. So if you look at Thirukaranathan's review in 2012, there is a chief mention of all these mechanisms, but the fluid resuscitation in acute pancreatitis pretty much reverses most of the pathophysiological issues discussed here. Now, acute pancreatitis, as you all know, is a disease where you have extremely wide severities. I mean, they can vary from absolutely a benign disease to a fulminant disease that can result in mortality. So some of the characters which have a high risk of poor outcome are listed here. Persistent organ dysfunction or system dysfunction at 48 hours. That means they call it persistent at that time, as opposed to transient, where it lasts less than 48 hours. And a lactate of more than 3 millimoles per liter. Some units use 4 millimoles per liter. Persistent SAR is more than 24 hours post-resuscitation. The presence of pancreatic necrosis, especially when it is more than 30%. Pleural effusion of pulmonary infiltrates indicating more severe disease. A blood urea nitrogen more than 20 or a rising blood urea nitrogen. That will be almost double for blood urea. A hematocrit more than 40% or a rising hematocrit. Age more than 55 years or the presence of comorbid disease or obesity. And if you look at organ dysfunction, systolic blood pressure of 90 or despite a volume loading, the PaO2 of less than 60, which defines hypoxic respiratory failure, a creatinine of more than 2, or a urine output of 0.5 ml per kilogram body weight for 1 hour despite the fluid loading, and some of the hematological parameters which we rarely see. So these are associated with poor outcome. But what I want you to understand is that many of them are related to poor organ perfusion because of inappropriate fluid resuscitation. I'm saying inappropriate because fluid resuscitation cuts both ways. So if you push to one end, fluids can become evil. And if you push to the other end, also it will become evil. So the best thing is to use in moderation. So this is how the pendulum of opinion about fluids in acute pancreatitis keeps changing. So, or in any other resuscitation parameter. So we have to balance the fluids that we use. So for fluid resuscitation in acute pancreatitis, the discussion probably starts with this. Nearly all patients with a hemoconcentration at admission of more than 44, and the earlier studies listed 47, who did not experience a decrease in the hematocrit during the first 24 hours of hospitalization, they developed pancreatic necrosis. Now this was from some of the key investigators are from Shanti Swarup Vigay's group and from Brigham Hospital. So this was their starting point. The initial hematocrit recommended was 47, and then they dropped it down to 44. So at admission 44 and a failure to decrease at 24 hours. Now, what exactly does this mean? Is it a marker of necrosis or a maker of necrosis? What I understood from the failure of the PCV decree is that you have under-resuscitated the patient. Persistence of hemoconcentration was strongly associated with the development of pancreatic necrosis. But just because you give vigorous fluid correction to correct this number does not mean that we can prevent pancreatic necrosis. That is a question we have not understood or answered even now. This paper was originally written in Pancreatology in 2002. 18 years since the time of the paper, and our understanding of fluids in acute pancreatitis has not improved much. Now, these are the key or the pertinent questions in fluid resuscitation in acute pancreatitis. What fluid to use, how much of volume of fluid to use, how fast we should administer, that's the speed of resuscitation, how long should we give this volume, the duration of resuscitation. Is it 1 hour, is it 6 hours, is it 12 hours, is it 24 hours, should we take it to 48 hours? So all those questions. And then what are we aiming at fluid resuscitation? So these are the questions which we will look into in detail now. Now, the fluid options in acute pancreatitis are like this. If you have answered some of our survey questions, you will understand them. Lactated ringers is the most popular fluid because of the studies indicating that it is very useful. The others is ringers ethyl pyruvate, which is not available everywhere. The other most commonly used fluid is the normal saline. And some of the units can use hypertonic saline. They are still under research. More balanced electrolyte solutions like plasmolite or colloids like dextran or hetastarch are also fluids that you use for resuscitation. Now, this Ringer's lactate is probably recommended because it has much less tryptic activity. The endpoint of Ringer's lactate-based resuscitation, as per our standard substance textbook of surgery, is that it produces a mild metabolic acidosis. Mild metabolic alkalosis. So lactate gets converted into pyruvate, and then it cuts down the cellular acidosis because of the production of bicarbonate. Now, ethyl pyruvate is a novel resuscitation fluid which has replaced the lactate in lactated ringers with a stable form of pyruvate. It is a potent antioxidant, and it can also downregulate the inflammation, and it can improve the survival in experimental animals with acute necrotizing pancreatitis. We also know that lactated ringers has been found to be associated with less systemic inflammatory response syndrome, and the CRP levels in patients who have had resuscitation with ringer lactate is almost half of that achieved by using normal saline. So, um, so today in our place, Ringer's lactate is still a very superior solution, which we can use on a day-to-day basis, probably because we do not have access to the other solutions. But in crisis situations, I would recommend people working in rural areas where you may not have large stocks of Ringer's lactate, pretty much impossible in our country, but it can still happen. Normal saline will still work good. 3% saline, the hypotonic one, has been found to facilitate pancreatic microcirculation, probably because it induces a shrinkage of the pancreatic endothelial cells, and because it establishes an osmotic gradient, and also modulates the neutrophil activity. So leukocyte adhesions, those things are changed. But hypertonic saline also has problems if the patient has underlying hyponatremia, and the rapid correction with hypertonic saline can lead to osmotic demyelination syndrome. So that is pretty much the biggest side effect of hypertonic saline. So apart from experimental situations, does not come down into the clinical practice. Obviously, dextran has been used in the older studies. Now people recommend hetastarch. Colloids can stay within the circulation for a longer time, but the current guidelines say that hetastarch is probably not very useful. We still do not have excellent data if we combine the use of hetastarch with a crystalloid to reduce the overall volume used in acute pancreatitis. That is something which we can look into as a group. Now, these are the resuscitation reviews over the last couple of decades. The first one, probably, which I was very much interested, came from Tenna, and the group recommended 250 to 500 ml per hour of fluid for more than 48 hours. Now, Tenna was very much interested because they are probably the dominant authority in acute pancreatitis at that time was John Ranson, and I used to calculate the fluid that accumulates in the body. He has a term for it. I'm not getting that. Sorry for the blankness. So if it exceeds 6 liters, the sequestered fluid, the fluid sequestered more than 6 hours, can lead to a more severe disease. So based on that premise, Tenner used that for 24 hours and divided that by 24 hours and got this 250. But if you look at the numbers, he has changed the time duration to 48 hours. So that probably led to a larger volume. This came on as a recommendation in his review, and a lot of people endorsed it. At the same time, I was working on fluid resuscitation volumes in Trivandrum, and our mean fluid volume at that time was 163 ml per hour, and that was far less than what was recommended by Tenner. But this was the premise. He probably miscalculated that 6 liters fluid sequestration and calculated it for 24 hours. Now, Whitcomb was the first one to use the fluid bolus to maintain hemodynamics. And later, he also followed the same tenet of using 250 to 500 ml per hour resuscitation. The actual fluids given at that time is extremely high. Otsuki is another, from 2006, was another review. The Japanese volume was completely different. It was 60 to 120 ml per kg. It's not based on hour, it is based on the kilogram, so it's calculated for the patient. 60 to 160 ml per kilogram per day, but the duration of resuscitation is not clear. And 1/3 to 1/2 should be given in the first 6 hours. Like every resuscitation, you have to fill the capacitance vessels, and that probably you have to address in the first 6 hours of resuscitation. So they have recommended the calculation. The total duration is not still clear. Forsmark changed use to crystalloids first, use colloids if the hematocrit is less than 25 or albumin less than 2 grams. That pretty much we are not using. For Pandol came to severe volume depletion. They used 1000 ml per hour initially, but the duration is not clear. Reduced to 20 ml in an emergency, and then 150 to 300 ml or 3 ml per kilogram per hour for 24 hours. That's usually about, for 70 kilos, it would be about 200 cc's. Thirukaranathan in 2012 probably had the most detailed one. We have many points to discuss from his paper. But even then, his endpoint conclusion was aggressive fluid resuscitation in AP needs to be initiated with a therapeutic intent. He has not defined what it is and how to do it. The last one to come through was from Wu's group. This is a multidisciplinary one. So they have just recommended that institutional protocols must be developed to ensure adequate fluid resuscitation, especially in the first 24 hours. So none of them have written after that. So the data on RCTs or control studies. So Mao was the first one to come with it in 2009. So controlled resuscitation offers better prognosis with better correction of fluid deficits within 72 hours. So that was the first one he did. The second one, and rapid hemodilution, that is a large volume resuscitation leading to rapid hemodilution leads to increased incidence of sepsis at 1 month and increased mortality. And now we know that very well. If you over resuscitate the patient, you may end up with intra-abdominal hypertension, problems in the lungs, and then sepsis, and probably a higher risk of death. So Mao was the one who initially did that. Three retrospective cohorts, again stating that more than 4 liters in the first 24 hours, more respiratory complications. And then administration of more than 4.1 liters, but not less than, was associated with more local and systemic complications. So if they keep on exceeding the volume beyond 4 liters, it's always dangerous. And Kubawara also saw this, that the fluid volume in the first 48 hours, if it is very high, they have not specified the number, but I think it's 4 liters, and they require more ventilation and cost a higher mortality in acute pancreatitis. Now, currently in the 2018 AGA guideline, it just says early goal-directed fluid therapy. There is no recommendation for using normal saline versus ringer lactate, but it recommends against the use of hydroxyethyl starch on a very low quality data. It's a conditional recommendation. So this is the tenors revision. It still continues to have that. Now, what we mean by early fluid resuscitation is the fluid loading within the first 24 hours of management of acute pancreatitis. Now, this early fluid resuscitation goal comes from early treatments in stroke, trauma, and acute MI. It's not fluid resuscitation. They all talk about golden hour where you have to treat MI, golden hour in trauma, and golden hour in stroke. So this pretty much mimics that. So what our thing is, all patients with shock, they were treated with early resuscitation goals and sepsis also with elevated lactate regardless of etiology. So that goes into the premise because tissue oxygenation in these conditions is impaired by hemodynamic failure, and you need a multifaceted strategy to aim adjusting oxygen delivery to the oxygen consumption. There is a huge metabolic demand on the tissues, and the delivery of oxygen to the tissues is also impaired. So we are going to correct one part of that. We cannot correct the oxygen consumption in the tissue anyways. So one of my early papers that I was very fond of was from Gardner. So it was strange that he recommended that 33% of the first 72-hour fluid volume should be given in the first 24 hours. Now this 33% is 1/3 of the fluid volume. So, and he does, I mean, there is no difference. He could have just said all the fluid must be divided equally in the first 72 hours. You calculate the volume and then divide it between 3 hours. So, now, there are 3 patient situations in acute pancreatitis. You have an overtly hypovolemic patient. The risk benefit is very clear. You have to resuscitate, you have to give a fluid bolus. Dr. Whitcomb is correct in this situation. NSRCA, edematous, congestive cardiac failure, renal failure, the risk benefit is clear. You have to give very slow fluid administration. You may need invasive hemodynamic monitoring. They have to be treated in the ICU. It is a very specialist situation. Neither of the above. The data is very hard to guess. Now, the ultimate goal of the tools aiming to predict fluid responsiveness is to find where that particular individual's ventricular hemodynamic status is located on the Frank-Starling curve. So you have to predict the preload dependence of that particular patient. So that is something you have to learn. Now, to assess this, I have put together a few things which probably people can use in their clinical practice. Now, fluid responsiveness is assessed by fluid challenge. So what you do is you give a fluid challenge to assess the responsiveness during a controlled volume expansion test. So you can give up to 200 ml over a 10-minute interval with a concomitant close monitoring of a cardiovascular response. So you take a larger unit where you are able to measure the stroke volume or measuring cardiac output as a product of stroke volume with heart rate. So positive fluid response is considered when the fluid loading leads to a stroke volume increase of 10 to 15%. But in pancreatitis studies, most of them have stopped at 10% for the fluid challenge. So this leads to optimization of the hemodynamics and good tissue perfusion, which is the ultimate goal of a good fluid therapy. So increase in stroke volume is considered a prerequisite. So you get a better pumping capacity from the heart and leads to better perfusion of tissues. And we expect because of that, we have a better oxygen delivery. Now, there are situations, I mean, you cannot have pancreatitis being treated in places where we can measure stroke volume all the time. So if you can't do stroke volumes, that does not mean that you should not use a fluid responsiveness test. So you can use BP-derived indices to help you predict the fluid responsiveness. The best used is the pulse pressure, and invasive pulse pressure. If you measure between systolic and the diastolic blood pressure, if it increases more than 17%, or in some studies they have taken 23%, they considered fluid responsive. And in a non-invasive situation where if you don't have an arterial line measuring the blood pressure, you can use a non-invasive. So then you have to target a higher pulse pressure of 35% increase to consider it fluid responsive. You can also, if you have a central line, you can also look for a bedside estimation of cardiac preload using a CVP. So as long as the delta CVP between the fluid bolus is less than 2 millimeters of mercury, you can continue the fluid challenge. And I have given the other one. If it is more than 5 millimeters of mercury increase, you can stop the fluid challenge. You can also use it as centimeters of water. The best probably what we were taught in Pittsburgh for volume was the passive leg rising test. So the patient's baseline position is lying down on the bed, half sitting, with a 45-degree angle between the trunk and the lower limb. And then the head end of the bed is made flat and the leg is raised up. The other simple way I think all of us can use is make the patient lie down flat, measure the blood pressure, and then lift the legs and hold it up. So you have to hold it up for 10 to 15 seconds. So that will be an increase up to 10% in pulse pressure. That will predict a lot of the blood volume. The legs will move into the heart. You don't have to give fluids. It will show an increase in the pulse pressure, which indicates that patient may respond to fluids. So be careful when you have patients with intra-abdominal pressure. So IAP, increased intra-abdominal pressure, will happen only with in the late phases of acute pancreatitis, not in the early phases. So it may not work in that situation. So I just want you to understand the goals, because this is going to come all over again in multiple studies. So the circulatory failure, the pathophysiologic target of circulatory failure is identified by the heart rate. And most of the goals are about 100 per minute. Some of them have mentioned 120. And effective organ perfusion can be guessed from measuring the MAP. So it is there is a formula which is available. So you can calculate that. A good MAP, or it comes in your multi-parameter monitor. MAP of more than 65 millimeters of mercury is ideal. A tissue perfusion is measured by using lactate, or in resource-limited circumstances, you can use the urine output. Janssen targeted this lactate is 20% decrease every 2 hours. But practically, this is not possible to do lactates every time. So we still aim to have a urine output. The urine output goal, most studies mention, is about 0.5 ml per kg per hour. But for some weird reason, I used 1 ml per kg per hour from the year 2001, and I still continue to use it. It's slightly higher, though I'm okay with people producing urine more than 0.5 and less than 1 ml. That is what I teach the nurses during the checklist protocol. Now, key studies, the other goal that is used in acute pancreatitis study is the utilization of hematocrit. So a lot of people have defined them, but the most common one I said was the PCV 47 at admission and failure to reduce at 24 hours. It came in 1998. It was considered a strong risk factor for pancreatic necrosis. Or a PCV of more than 44 at admission, failure to reduce at 24 hours. That study came in 2000, again a strong risk factor for pancreatic necrosis. But pretty much Lankish, Pizzelli, and Wu in 2000, we do not know. There's a lot of confounding factors in using hematocrit. So use your hematocrit, but be very, very careful. Now, using all these multiple goals, I have put up a suggested algorithm. So this, you can use inadequate tissue oxygen. You can guess and assess the risk of high fluid overload and then give the fluid challenge. So, and supportive therapies like blood cell transfusion, oxygen, mechanical ventilation, pretty much a lot. But of all this group, oxygen is probably the best commonly used one. Sometimes, apart from analgesics and sedatives, we never have to use vasoconstrictors or vasodilators. We have never, I think mechanical ventilation has been very rare in our group. So that is one more, that is how you put all of them together. And some of the studies in acute pancreatitis mentions this SVO2, the central venous oxygen saturation. I've given the formula. My policy is that I don't use the central line, so I never use the SVO2. And one of the senior intensivists in the city told me the problems in the reverse study in surviving sepsis guidelines and the bias behind it. So I stopped using this SVO2 long time back, even in patients with sepsis. Now, how much volume to give? Now, I told you, Wu and Cornwell in the 2010 update in current gastrointestinal gastroenterology and reports, they have suggested a volume infused of about 60 to 120 ml per kg for 24 hours. And the Japanese targeted the same thing, which I've been using for a long time, 1 ml per kg per hour. And that's a very good flow. And this is the tenor group from 2001 from the AGJ. So what they have done is just given a fluid of 250 ml per hour. The target is very unclear. So this is how it is. So what they have probably done is the 6-liter sequestration over 24 hours. You get 250 ml, but probably the mistake was the time duration. If they had made it 48 hours, it would be about 125 ml. If it is 96 hours, it will still drop further. We do not know whether these volumes are actually good to prevent morbidity in acute pancreatitis. The IAP or the APA guidelines mentions about 5 to 10 ml per kg per hour in the first 48 hours. And the heart rate target is 120, less than 120, MAP of 65 to 85, and a urine output between 0.5 to 1 ml per kg per hour. Now, if the patient is hypovolemic, 20 ml per kg fluids wide open, given in 30 to 60 minutes is a good start. And then followed by 3 ml per kg per hour for 24 hours. And then followed by 2 ml per kg per hour if they respond to resuscitation, and 3 ml per kg per hour for refractory patients. This is a widely recommended protocol. What we have done over several years is a different one. And I failed to mention that the more hemoconcentrated they are, the more aggressive your fluid resuscitation must be. Now, I came from a very different policy. We started with 1000 ml ringer lactate at 1 hour. That was a fixed one. It was not based on weight. It was not based on the body surface area or anything like that. It was given at 1 hour. That was the bolus. Probably we aimed at filling the capacitance vessels, just like how we do in burns. And if the urine output drops to less than 0.5 ml per kg per hour, we double the rate. So that's in the first hour. we never exceed 3 liters at that time. Most of them with the bolus, they usually open up. We usually put a Foley catheter at admission with 0 hour. We have a hover by hour assessment for the first 96 hours. That was very intensive. But the nurses at CSI Kalyani Hospital were very, very cooperative. They used to do it hour by hour. And most of them used to manage it without me, not even shifting the patient to the ICU. At 6 hours, if the patient is not responsive, we used to minimize and assess the renal function. And some of those patients who have not responded, we have used peritoneal resuscitation using some method very similar to the peritoneal dialysis. And these patients also recovered very well, maintained a very good fluid balance. This is the University of Michigan fluid therapy for acute pancreatitis protocol. They use a crystalloid, which is ringer lactate. Their infusion rate is 5 to 10 ml per kg per hour. Look at the goals. It's the same. It's the IAP guidelines. And they advise caution in patients with age more than 55 or pre-existing organ failure. And once this is done, the goals are achieved. A continuous fluid therapy at 3 milligrams per kilogram per hour. But at 6 hours, they check the BUN checkpoint. If it should be less than 20 or falling. And then once S, they maintain to 1.5 ml per kg per hour. That is really good. They have really come down on the volume. So that is what is a good one. As soon as you get the fluids in the capacitance vessels, your stroke volume is good. You're increasing the stroke volume without increasing the CVP. You're in the right phase. And I think whatever you should replace after that, it should be guessed on the organ perfusion. Now, this is one more comment. You may end up overdoing the fluid resuscitation. So DiMaderia wrote a beautiful paper on this, on the prognosis of acute pancreatitis. So it was mentioned in the review previously. So if you have more than 4.1 liters of fluid in the first 24 hours, there is a significant increase in persistent organ failure and local fluid complications. So if the patient is not able to get the fluid out by as a urine, that means you may end up pushing more fluid into the interstitium. That's a very big risk. So this is probably a bird's eye view. Last 10 days, we ran the LGS Acute Pancreatitis Study Group Index Survey data. And I wanted to share some of them because I wanted you to introduce, to encourage many people from taking that. We received a total of 112 responses, which is a very minuscule response compared to the number of members in the LGS group. I would have loved to see about 1,000 responses about how this is going on. We intended to shut it down today and then look at the data. So among them, we found that 67% of them used Ringer's lactate, and you still see 26% of them using normal saline. So that pretty much still has to be left open. A small group mentioned that they have no specific fluid. That usually comprises of intensivists using fluid resuscitation. We do not have solid data on what kind of fluid they use. So that is one interesting data which turned up. The second one was how much fluid bolus. So you can see that up to 20% of them give no fluid bolus. So they give maintenance fluids, which is good. And if they are able to achieve good results, I want to look into the data and see how they are managing those stuff. See, in acute pancreatitis, like I said, these answers are never complete. And we really need to know whether the papers that are written from organizations, institutions like PJ Chandigarh or AIMS, they do not actually reflect what is happening in the community where it is managed by general surgeons, general practitioners, and general physicians in non-specialist, resource-limited circumstances. And I find some of them doing very good with all this management. So I actually want to see whether the type of pancreatitis they see is different and the amount of fluid they give is probably reflective of the right amount of fluid that needs to be given to the patient. So if you look at still just under 50% of them give 20 ml, and a quarter of them, slightly under a quarter of them give 30 ml per kilogram body weight, which is the sepsis resuscitation volumes. So still, we have a large variety of bolus fluid in acute pancreatitis, and this will be one of the data we would love to look at from the community. Now, this is another. We have we asked them what are the monitoring parameters that you use in acute pancreatitis, and I expected 100% of them to use hourly urine output. No, about 92% of them use it, and it is still good. I mean, these are real data, and it's very nice to see. A lot of them use SIRS, some of them use monitored PACS cell volume, a few of them use lactates and base excess, and 83% of them monitors saturations, which is very good, and some of them monitor MAP. So a good variety of these modules are seen, and these data needs to be analyzed for us to derive some concrete conclusions from that. Now, why I made this presentation was that most of the questions in fluid therapy in acute pancreatitis is poorly answered. Whatever I presented to you is incomplete data. So the volume questions are how much volume, index volume we should give, whether it should be weight-based or body surface area-based, we do not know. And only if you have honest, solid data, raw data for fluid volumes, will we be able to look at the different calculations. What we find is that some of the fluid charts will not have the weight documented or the height documented, and the body surface area could not be calculated, the BMI could not be known. So all that we saw in, I analyzed an audit in 2 hospitals in Chennai and found a lot of gaps. It can be another presentation, but these are not answered. The maintenance, whether it should be based on hourly volumes or weight and time-based volumes, should the maintenance fluid should be goal-based, and whether that goal should be an invasive goal or a non-invasive goal is still not answered. There are no endpoints as to when to stop fluid resuscitation in acute pancreatitis. I stop it when the patient takes enough oral fluids and to match his requirements. That is the time when I discontinue all the IV fluids. But I want to, I mean, that looks pragmatic, but I also want to see others' viewpoints on this. And we do not know whether we can use oral fluids. I had a unique experience in which I had to manage a patient on a moving train. So we had no IV fluids, and we managed them with oral rehydration solutions for resuscitation, and it worked very well. He did not develop necrosis. And we also do not know how to do good resuscitation in acute pancreatitis with renal failure. There are beautiful reviews written in the Canadian Journal of Nephrology on this, or in resuscitation in AP with cardiac dysfunction. So my presentation is that, can we answer these questions in the Learning General Surgery group of the, and a part of that we have created the acute pancreatitis study group. Pretty much everyone is welcome to join this group and join in the data collection. And the second question is, can we maintain a database for all, especially our younger members, to assess and derive their own conclusions about the disease nature? This probably was a very common one. I'm sure with a large group like this, we may be able to answer much more questions in acute pancreatitis. Like they say in Africa, if you want to go fast, you go alone. But if you want to go far, go together. I wish we could go further. So my thing is that, can we do a prospective multi-center fluid resuscitation data in acute pancreatitis through a social media collaboration platform through LGS AppSig? So we will need close to 200 to 300 collaborators. Each one can have access to data. And I would like the youngsters to look at these data, interpret the new paradigms in acute pancreatitis and fluid resuscitation, and then take this to a new level. This is just my small idea. I wish others can contribute on this. Thank you.
Wonderful lecture as ever, Ilango, and very inspirational. And I'm sure now this is a small beginning, and it's good that at least 100 responded. I'm sure with repeated appeals, I think more will come into taking part, and we'll spread the word. We'll just keep constant mm, dialogue with our members to. Chalapati, want to say something?
Yeah, very nice presentation, Dr. Ilango. Actually, very nice. Actually, you have. Am I audible?
Yeah,
Yeah, you're
yes.
Okay, right. Yeah, very nice presentation. So I'll just discuss the end part of your lecture first. So actually, you took me to 4 years back, whatever you have actually proposed about the collaboration and all. So if you remember, Pata sir and all were very enthusiastic, and some time back we started on some kind of study group, especially hernia group. Though I'm a medical gastroenterologist, we want to get the ball rolling. So we created some kind of doctor along with Dr. Bhavin, I think. So hernia group. So we started and we got some good responses, but somehow there was some kind of inertia from my side, and there are various reasons it didn't take up. So I would really love to be part of this group. If to share my data, we keep a database of our acute pancreatitis group. So many congratulations for coming out with such kind of thing. So the second thing, actually, I liked the monitoring parameters that you actually mentioned in your presentation. But what of late we started doing, or in fact, there is some data that is coming up, which is probably not touched in this presentation, of two things, that is usage of ultrasound, that is lung ultrasound, and the measurement of the IVC diameter correspondingly on a regular basis, and see how how the diameter of IVC is behaving, and how the collapsibility in end inspiration comparing like that. So that is one thing. And also about the lung ultrasound, to look at the Kerley B lines and all, to see the hyperechoic shadows, which indicate fluid overloaded lung, in fact. So I think these two things are quite attractive. Why? Because it can be done even in the most periphery of the country. Probably it doesn't require any central line, because not many people are well versed to put a central line or arterial line. Many ICUs, or in fact many of the centers, may not have a regular access or a periodic access to the echocardiography to measure the stroke volume, etc. So I think these two things are very attractive to me, that we are following in our unit, and we see that it is quite useful. We monitor maybe at least twice a day because of some availability issues, but still we are able to manage, and that guides us to the fluid resuscitation. Yeah.
Dr. Chalapati, I actually do not encourage the use of stroke volume.
Yeah.
I just want to cover all that.
Right.
So, is my screen sharing on?
Yeah.
Yes.
Right. Yeah.
So this is
Very
a
detailed one. Very detailed one. Yeah.
electronic health record.
Right.
This is something which I created for the LGS group.
Nice.
So I'm testing it several times in several modules.
Mm-hmm.
So this was developed in 2011 with Dr. John Windsor helping me out.
Mm-hmm.
We had the same issue, that I would be able to come to the hospital only a couple of times max, and these pancreatitis would never be resuscitated appropriately. They would be in the ICU. We used to see necrosis. So that was really a pain. So we created the acute pancreatitis checklist record, which runs for 96 hours. And it's pretty intensive. So if you can look at the monitoring parameters, I can show you that it has a pain score, a
Right.
temperature, heart rate, respiratory rate, systolic and diastolic BPs, saturation, and then it has it monitors the hourly urine output. It also has oxygen supplementation, the fluid type, hourly urine output, measures a few parameters, and has an hourly fluid balance. Now, this hourly fluid balance was not in the original paper format. It's very easy to do in Excel, but the original one did not have that. And it was a nurse-run checklist. It does not require a consultant. Meets these following criteria. They check the amylase. They know when to do the CT scan. They order a plain CT scan, and they know from the report what to get, and they can inform me. and they can fill up these forms, and it will tell immediately whether they have a organ failure, their age is high, the BMI is high, or they can look at the modified Glasgow clinical severity score, which is the easiest for them. So we use that, and using those criteria, I mean, now I have modified it much more simpler, and then predicts. It also tells them to look at the etiologies. I have asked them to look for only 2 etiologies, whereas alcohol or biliary, they have to identify biliary. So they will look at the ALT more than 80 within 24 hours. So they will do all that stuff. They'll fill and with good resuscitation, we found out that very few of them develop necrosis. I think that group, we had 2 necrosis. One was a young girl with ascaris-induced pancreatitis, and she went on to develop necrosis. Another patient was resuscitated by a junior surgeon friend of mine. He did not give much fluid in the first 24 hours. The patient developed renal failure, pancreatic necrosis, bled into the pancreatic necrosis, and that was one of the open necrosectomies I remember for a long time. So this was how we developed. What we wanted to know was that, to keep this very simple, we wanted to build how to look at this. If you can see the center of your screen, now this Excel sheet has a consultant or attending working area, which is completely auto-filled. It's completely auto-filled, meaning that it will tell you by just looking at the end of all the timelines, 6 hours, 12 hours, 24, 48, 72, and 96 hours. How to do that? It will tell you the cumulative fluid balance, which I did not use in the initial checklist, but I learned it from my training in US. We also have the percentage fluid accumulation, should not go beyond 10%. That indicates you are at very high risk of respiratory failure, higher intra-abdominal pressures, and all the intake output gets dropped. So you have all the goals. You have fluids in ml per kg, ml per kg per hour, the ml per hour, and you can even, I have even put one for the calculation by minute to look at the different ways we give fluids in acute pancreatitis. And PCV, lactate, and base excess can be entered. In organ failure assessments, we look for urine output. So this almost touches 1 ml per kilo per hour, which is very, very good. And then we can also enter the urea creatinine values, and it will tell us exactly, I mean, Excel is quite easy. And then the mean heart rate, the temperature, respiratory rate, and the total count to pull up the SIRS, how it changes. So these are the things you must do. And probably the urine output in ml per kilogram, it will clear whether you can start the oral intake initiation. I usually don't give them fluids at the time when I'm giving a lot of fluids for resuscitation. So I wait for the end of that resuscitation goal, and they invariably, they feel better, and then they take their oral fluid. And I do the CT scan at 96 hours to identify necrosis, and then they have the CTSI score, and we complete the counseling for alcohol. Sometimes we miss them. And for biliary pancreatitis, we use a same admission cholecystectomy. We also have a checklist for discharge criteria. So we put this up. We are wondering whether we can incorporate this online for people to use it on the online and enter data and probably help them. This is the discharge part of that. Thus, it assesses different components for them to meet all the discharge criteria. So what our primary aim was not to get into this detail. We wanted to treat acute pancreatitis with as minimal interference as possible. So this was what we tried to do. None of the stroke volume calculations, nothing will be here. So we use the urine output as a surrogate for organ perfusion in the pancreas and in the other structures. I think this also leads to good bowel perfusion, and we have never had any issues with raised intra-abdominal pressures or massive necrosis. We have had necrosis in these patients, but most of them did not require any intervention. So we try to keep them. Most of our necrosis, which I have operated, are all from outside. So this is probably what we wanted to do in learning general surgery in the next few months to a year, so that we get the actual data which they use. I mean, as long as they enter the honest data, it will pick up for them. It will help them in the clinical decisions, and will also probably evolve into a good database. That is my call.
Excellent, Ilango. So I think we'll start working on it and hope we'll reach some point. Any
Sure.
any other comment or Ashok Kumar?
Sir, I have a couple of questions from Dr.
Yeah.
Ilango. Now, first, he talked about the fluid resuscitation in details. What that fluid resuscitation was for acute severe pancreatitis, isn't it? So, what about the resuscitation in mildly severe pancreatitis and mild pancreatitis? Is it the same, or you have to change some bit?
So in mild acute pancreatitis, I mean, you cannot distinguish them in the initial phase. Once they present, you presume that they can go in for severe disease, and you give them fluid resuscitation, and then you assess whether they are mild. So you can assess them later, but I think the initial phase when you're resuscitating, presume that they are, don't distinguish between them and don't change your resuscitation protocols between mild or severe disease. No, mild disease is one which does not have organ failure or does not develop necrosis, but that all happens after 96 hours. So that is hindsight. So you will never be able to guess which one is mild. Even the very benign looking pancreatitis will quickly deteriorate if the fluid resuscitation and the supportive care is not good.
Okay, thank you, sir. Thanks.
Any other comment?
So Chalapati asked one more question. What's the data on peritoneal fluid resuscitation? There is actually no solid data on that. John Ranson, in one of his seminal works, described peritoneal lavage for patients with renal failure and acute pancreatitis. And they are one of the difficult ones. So you give them fluids, they don't respond. So he was using that. And this was in the year 1997-98 when I was influenced by his work. So when I came into practice, when I used to face this, I took that reference and started using the lavage. The lavage actually clears most of the cytokines in the peritoneal cavity. You can see an immediate hemodynamic response. But after some time, I used to continue that for 24 to 48 hours and then pull off the Riles tube. I used to just put a simple Riles tube through a subumbilical incision because I was working with a nephrologist and I used to put the PD catheters for him. So I used almost the same protocol. Antibiotics at 50, I think I used cefotaxime at that time. They had a very, very good result. And most of them came out of renal failure. And the fluid balance was very good. Then we discussed this with John Mincer from Auckland. And then he said it's not so useful. I still managed to do some of them in critical circumstances because I don't want them to go in for CVVH or hemodialysis, and this works very well. I have never seen them develop increased abdominal pressures, and there is no increase in necrosis or any infection. What we have found is that that incision is slightly larger and it has a risk of hernia. For one patient, I had a herniated bowel which became necrosed. But by then we had completed the resuscitation. We took him and did the resection and anastomosis, and he did well. So it's quite rare. I think I have done close to about 7 or 8 patients in this last 20 years. Not a very common thing, so we will not have robust data on this. Thank you.
I suggest, Ilango, I think fluid resuscitation to start with is a very good subject, and you see that there's no proper understanding across the population, and I think it's one very simple concept to understand and make it uniform across the country. So I think you need to form a group of maybe 5-6 people of this acute pancreatitis group and expand the horizon. And I think we should keep working on it. Well, Chalapati, what do you say?
Yeah, I mean, but there was at the time there was a query that how are you going to check the honesty and authenticity that a clinician is actually entering the data because it is completely online. So the same question was raised 4 years back, and again the same question will be there, especially with the kind of elaborate Excel sheet, if we, for example, if we circulate into the group, I don't know how much it will be. It's not a question of discouragement, but we need to work out all these kind of.
How is it done elsewhere?
Sir, elsewhere, see, it is driven by the personal institute protocols. They just see the whatever studies that were presented just now in this presentation. They are very heterogeneous. One group, monitors the urine output. One group monitors the PCV. One group monitors the stroke volume. It is quite heterogeneous, and it is driven by the, the most likely, I feel like it is driven by the available parameters in those kind of retrospective studies. There are very few prospective studies which were actually highlighted, but they are mainly on urine output, definitely, and it is quite heterogeneous. So whatever is convenient to that kind of institute, the particular clinician will follow that. So I think still there is a lot of debate, or there is no consensus what is the best parameter, but it is definitely urine output because it is very convenient, but many people follow different protocols.
Well, regarding the honesty part of it, I think when it comes to a surgical procedure like hernia, people, some of them may not be honest enough to quote the exact figures, but I think when it comes to acute pancreatitis, I mean, that percentage should be quite less. Some bit may be there, but I think you all as the group can assess and find out whether, how much authenticity is there. I think, but we had to make a beginning. We can't, because for a country of our size and also for a group of our size, I think it's time we work on it. I think Ilango has taken a good initiative, and then we all have to sit together and communicate from time to time and make this happen.
Yeah.
Ilango?
Yes, sir.
Yeah.
I have one last comment. So from my side, at least. So actually, you have beautifully elaborated that 0 to 96 hours is very critical. 24 hours, 48 hours. So a lot of studies are there. But what makes it different, probably everywhere and especially in India, is that we may not be seeing the patient on day 0. That is a problem, right? So if we are sitting at the tertiary level hospitals, whether it is a corporate, private, or institute level, most of these patients are referred to us because of some kind of non-improvement. They must have already elapsed some 3 days or 4 days in their course of illness. So most of the day 0 or day 1 cases are managed right at the periphery, either misdiagnosed or diagnosed as acute pancreatitis. So by that time, probably the golden hours are already finished. So but still we'll do our part. We have to do our part, but by the time, the damage must have already occurred, right? So when we are actually trying to understand this kind of concept of fluid resuscitation, it is very important on which day of pancreatitis are we seeing this patient, or did the patient get transferred into our setup. So depending on that, we need to tailor our protocols. That becomes a real challenge to bring in the homogeneous data to this group. What do you say?
So the aim is not for us to treat. The aim is to encourage the youngsters to see. I have personally, I see only either it's a VIP or somebody known to the MD, and I see a patient with acute pancreatitis. Most of them are managed in medical gastroenterology, sometimes in general surgery, and I don't get to see enough. Some of them are managed by intensivists themselves. So I am not discouraging them. What I want to say is that this is a disease which must be managed very well by the youngsters who are just fresh out of their graduation studies, either MD general medicine or general surgery, whatever, wherever they may be, and some senior MBBS too. So the senior MBBS are not a part of our group. Most of them are not part of our group, but I think the youngsters are, and they can treat these patients very well. And if they are honest enough and they are able to enter their data, that bulk will give them a better view of the treatment of acute pancreatitis. And in a way, I feel that the world that is seen by a generalist is completely different from That's seen by a specialist. I mean, here we are called for bad necrosis, organ failures, ERCPs, urgent ERCPs, or bad biliary pancreatitis, things like that, which they cannot manage, which I think is a very small percentage. Years ago, I was doing a review of charts, posters with Dr. John Vincent, and he showed a poster which showed about 50 cases of bleeding complications in acute pancreatitis from a single institution over a period of 2 years. He said, wow, that's a big number. I said, it's a referral institution. I said, Ilango, just look at the statistics and understand it's just 1%. 1% of them develop bleeding complications in acute pancreatitis. If you have 50, so you have to have 5,000 patients over 2 years. It's an impossibility. So I could see the wisdom in his words. So I started seeing every data like that. And that's how I ended up cynical everywhere. But what I want to know is, let us keep the things open, encourage the youngsters, and look at the data. We might have a completely different picture ourselves. So let this be a beginning. We can have databases for everybody, for the youngsters to use. There are a lot of people who are extremely quiet here in this forum for several reasons known only to them. But the least I can do is putting together a database which people can use. This is a huge platform. I mean, no other place will have 33,500 members, all from different specialties. I think we need to do something solid at this point of time. Our video library is growing every day, and it's almost like a medical school. Isn't that, Patta sir?
Yeah. Yeah, actually this, Chalupati, we are associated with this for so many years now.
Yeah.
But then this didn't die down like many others.
Should not. It should not.
It's growing, and some of us are constantly at it to make it grow, and it should grow further. Actually, at any given day, there'll be at least 50-60 people joining. What are they looking for? We really do not know whether they're getting what they want. I think all these newer ideas have to infuse. Ilango and Jalpati are all scientific people with a scientific bend of mind. I'm not so much. I take things very easy. So you people have to drive this momentum, and just keep it going. So I think we will work on this very, very persistently for the next 1 month on acute pancreatitis. Let this be the first group, scientific group like that. Many groups can be found for many diseases, but I think we shall try this out and see how things work out.
Sure, sir. Okay, sir.
Okay. Nice seeing you all, and have a nice Sunday. Take care. Thank you. Thanks for the time, Ilango. Thanks.
Thank you.